So good evening, everybody, and welcome to the ASGBI webinar series. This evening, we've got the team from GE Healthcare with us, who are going to talk to us about the cost-saving benefits of continuous vital sign monitoring in patients, both in the medical and surgical setting. We've got two fantastic speakers for you this evening. We've got Dr. John Beard, who's an anesthesiologist from Chicago, who is now the Chief Medical Officer for the Patient Care Solutions. He has been recognised for his contributions to healthcare and creating a company and products which actually have an emphasis on improving patient care and improving the working life of healthcare workers in terms of medical staff and nursing staff on the ward. Alongside him, we've got Dr. Luchetti. He's originally from Italy. He was also an anesthesiologist and he's now the medical director of GE Healthcare. A senior consultant who's worked both in the intensive care, pain medicine and anaesthetic setting. He's got over 70 peer-reviewed publications, many of which focus on improving outcomes for patients in both medical and surgical settings. So without further ado, we're going to go ahead with our first speaker. So next slide, please, Vicky. And I will hand you over to Dr. John Beard. Thanks for being with us this evening, John.
Thank you, Sonia. Able to hear me okay and see the slides okay?
Yes.
All right. Well, thanks everyone for joining this evening. It's a real pleasure to be here. And this is a topic that's near and dear to me. And I think it's a real opportunity for healthcare providers of a variety of different specialties to improve the outcomes of hospitalized patients. This is titled Clinical Outcomes of Continuous Ward Monitoring, but I'm going to kind of start out with defining what the evidence is that indicates there is a problem here to be addressed with technology. And then we'll hand it off at the end of this session to my colleague Marco, who's going to talk a bit about the economics. So we're going to do a patient safety reality check to get started, and then we're going to look into some other aspects of the literature I think you'll find interesting. How do we identify patients prior to adverse events? What's our performance in detecting abnormal vital signs? If we do implement continuous monitoring in the medical surgical ward environment, what's that look like? And then we'll take a look at some of the outcomes and then finally look at the barriers. So I think getting started, here's a reality check. And this comes from BJA a couple of years ago, Doctors Flick and Saugel. Surgery went well and everything's fine. Your relative is still in the operating theater, but you can visit this afternoon on the ward. So sounds pretty comforting. And each day, thousands, tens of thousands of patients hear this information, but what's more reflective of reality would be a call like this. Surgery went well and everything's fine so far, but the most dangerous time is still ahead. The postoperative period poses a much higher risk for patients than surgery itself. It's pretty jarring to hear, actually. And I think as we go through the following pages, you'll see that there's substantial evidence that supports this statement and again defines an opportunity that all of us may have to improve the care of patients. So here's a paper that comes from Bainbridge in 2012 from the Lancet. These researchers looked at 87 studies that included over 12 million anesthetics and surgical patients. And what they found here, this is purely anesthetic-related mortality. So the practice, the science of anesthesiology was associated with significant morbidity and mortality up until the 1970s, has improved significantly. That table's a little bit busy, but if you look at the top row, that's the global numbers. So deaths per million anesthetics due to the anesthetic alone has decreased substantially. The high human development index countries, not surprisingly, have seen a greater improvement than those with low human development index ratings. But this is to say that safety in the operating room is improving. And this is also accompanied by improved surgical techniques, advanced training of surgical specialists. So it all has contributed to improved intraoperative patient outcomes. But we also know and this comes from the Lancet in 2019, that if postoperative death within 30 days of surgery was counted as a diagnosis, it would be the third leading cause of death globally. That's a little shocking to hear, but it is supported by additional studies. So here's a paper that was done by Spence, published in 2019 in the Canadian Medical Association Journal. And this was a prospective cohort study, 28 sites, 14 countries, and they looked at deaths within 30 days. There were a total of 40,000 patients enrolled. And you can see there in that figure that's up, the leading cause of death included myocardial injury, major bleeding, and sepsis. And those, march out over a timeline after in the postoperative period. I think what this paper really contributes is some idea about where are these deaths happening. So we talked about the operating room as being pretty safe due to advances in surgical technique and training and anesthesiology. Of the patients who died in this study, so it was almost 2% of them, 500 of them died in the hospital during the initial hospitalization, and then 210 of them died at a later period. Here's another study that comes out of a European cohort, and this was published in 2012, also in a Lancet by Pierce. And in this study, you can see there in that figure, a number of countries participated here. We have 46,000 patients, major non-cardiac surgery, 4% mortality rate here in that initial hospitalization. What's interesting here is that during that initial hospitalization, 73% of the patients who did not survive never were admitted to the ICU, suggesting that those patients are dying in the medical ward environment or the surgical ward environment. Here's another study that comes from Pearman, and this is a retrospective review of in-hospital cardiac arrest, 445 hospitals, 85,000 events. What they found here was that those events are happening in the ICUs and on the floor. If you see the figure there, you can see the cardiac arrest per 1,000 inpatient bed days displayed, with the inpatient ward being that pink tracing. And what they found in their data, out of that large number of arrests, 41% of them were happening on the ward. This is the study that comes from NHS in 2014. This is 22,000 patients, 144 hospitals in the UK National Cardiac Arrest Audit Database. And here, those researchers found that 57% of these arrests were happening on the ward. So there's a significant amount of morbidity and mortality that patients are experiencing in that intermediate acute care environment. So I think the question for us as clinicians is, can we intervene, identify these patients earlier, and prevent some of these adverse events? If we're going to do that, we need to be able to identify these trends earlier. And fortunately, there is evidence that we can identify these at-risk patients earlier. So this comes from Anderson in 2016. These are several different plots of vital sign abnormalities associated with patients who did have cardiac arrest. So we can see that elevated heart rate, elevated respiratory rate, and low blood pressures were all associated with in-hospital cardiac arrest. We can see that 59% of patients had at least one abnormal vital sign 1 to 4 hours prior to arrest. Suggests that if we're able to identify it in that time window, we're going to intervene effectively, or at least have that opportunity. And then 13.4% had one severely abnormal vital sign. These researchers also looked at the association between multiple abnormal or severely abnormal vital signs. And not surprisingly here, the more abnormals you have, the higher the probability of mortality. Another study looking at vital signs preceding adverse events. This comes from Bedoya 2020 in the journal Respiratory Care. And this case, the researchers looked at 450 patients who had unplanned intubations. And in these cases, each one of these figures represents a trend of vital signs prior to an event. Some of these trends began 5, 10, 15 plus hours before. What these researchers found, with 54% of patients had significant vital signs changes preceding this event. What's very concerning here, however, is that 46% of patients had no recorded abnormal vital signs. I think intuitively, the probability that someone has no abnormal vital signs prior to requiring an unplanned intubation, that just does not make sense. This suggests that these abnormals are being missed. So let's look at our ability to identify abnormal vital signs in our current care processes today. So this is a slide that started with Alparsalan Turan and Dr. Ashish Khanna, and I got their permission to use it here. Going from the operating room to the ward environment leads to a significant change in how patients' physiologic status is being surveilled. So we know that safety in the operating room is very, very high. If we look at this example, you have a surgical time of 130 minutes and say that's the anesthetic time as well. Blood pressure is every 5 minutes. More likely that it's going to be more frequent than that. Every 1 minute in some cases, 2.5 minutes, 3 minutes, and many more cases. Those patients, if it's every 5 minutes, had 26 blood pressure measurements in 2 hours. Then that patient goes to the floor. Length of stay is about, let's say, 3 days in this case. They're getting blood pressure every 4 hours. And they're now getting blood pressure 18 times over 3 days. So there's a huge opportunity between those measurements for something to happen with that patient and for it not to be recognized. And then when the patient is discharged home, there are many places globally where home surveillance is being stood up, and it's being used in more and more locations, especially after the pandemic. But many patients just go home and there's blood pressure is not going to be measured again until that next visit, either to the hospital with a deterioration or to the surgeon's office or medical doctor's office as part of a follow-up. So patients fall off this cliff of monitoring frequency. What are we missing? So one of the things we're missing is hypotension. So this is a study that came out of Cleveland Clinic several years ago. It's been really influential, I think, in how clinicians view postoperative hypotension. 2019 in the journal Anesthesiology. So in this case, these are patients who went to the floor. They had continuous blood pressure measurement with a wireless wearable device. Clinicians were blinded to those measurements. And these patients were instead managed with intermittent vital signs checks. In this case, it was identified that 10% of patients averaged at least 10 minutes per hour having a MAP of less than 65. MAPs of less than 65 get into that range where we expect there's going to be some myocardial risk and some renal risk. We also observed here that 47% of these hypotensive episodes with MAP less than 65 were missed during the vital signs checks in this institution. This all suggests there's a lot of hypotension taking place in the ward environment that we're not aware of. Similar study here by many of the same researchers looks at post-op hypoxemia. This is also remarkable. 21% of patients in this study, again, these are continuously monitored patients, but clinicians are blinded to that continuous measurement. 21% had SATs less than 90 for at least 10 minutes per hour. And we think about the oxygen hemoglobin dissociation curve. Once we get to 90%, that desaturation curve is pretty steep. So these patients start to incur some significant risk there. 90% of episodes with SATs less than 90% for greater than an hour were missed during the vital signs checks. This is suggesting that our current process of care is missing significant data. Another related study from many of the same researchers, they took this large data set and they estimated with the intermittent nature of checks, what's the percentage of all episodes of hypotension and desaturation that's going to be missed? In this case, they concluded that roughly 80% are going to be missed. This is not suggesting that the nurses are measuring incorrectly. This has to do primarily with the fact that these checks are intermittent and widely spaced. The spacing of vital signs matters. So this is a study that has identified the root cause for unplanned ICU admission. In this particular case, the top figure there, you can see a healthcare worker related is the largest contributing category and root cause. And within that group, monitoring is the largest driver. And these researchers determined that about 40% of vital signs actually followed to the T how those vital sign measurements were ordered in the patient record. Some of these vital signs regimens can be difficult. Here's one example of them. So this is a study that looks at vital sign compliance on a general hospital ward. And in this particular image here, we're looking at vital signs measurement compliance for patients who had a high Muse score. So once a patient has a high Muse score, oftentimes those clinical protocols move over to more frequent vital signs checks. In this case, that green bar in this figure indicates that with a high Muse score, vital signs are to be measured every hour in these patients. In this case, staff in this care environment were only able to measure vital signs Q1 hour about 1/3 of the time. So the compliance is challenged. Here's some additional evidence of why intermittent vital sign measurement can be a problem. So this is a study that came out of what's called a closed claims analysis. These are patient injuries that went to lawsuits. This was a study done by American Society of Anesthesiologists. We can say in this group of patients, there were 92 claims that were assessed to be opioid-induced respiratory depression. The reviewers determined 97% were likely preventable. What they also identified here is that life-threatening respiratory depression can develop rather quickly. So this bar there with that red circle, 12 of these patients had a respiratory depression episode that led to harm within 15 minutes of a nurse's check. So it's something that can happen very rapidly. So if we go from intermittent to continuous, what's that going to look like? So this comes from Dr. Ashish Khanna. It's just it's a nice illustration. It's very intuitive about how continuous ward monitoring is going to look. So we look at this first panel here. This is a patient at 4 a.m. looks good in that top picture. At 4:40, the patient turns blue, which is not good. At 6 o'clock, the caregiver comes to the bedside to take vital signs or check in on the patient and recognize it. So we have that gap in time. 6:15, there's the full recognition of the patient's condition, and that patient has potentially been harmed. What changes with continuous monitoring is you go to that panel that's 4:40 a.m., that patient's condition changes and it creates an alert that brings that provider to the room. In this case, the authors are suggesting that the provider's in the room within a couple minutes, identifies this change in condition and can provide therapy. An additional futuristic view of what's this going to look like comes from Dan Sessler from Cleveland Clinic and Bernd Saugel from Germany. They're suggesting that in addition to this continuous ward monitoring in the future, which is going to create alarms that clinicians respond to, that eventually those alarms are going to be filtered through some software system, AI or rules-based or other, potentially then interpreted by a central monitoring unit that's then going to contact providers and direct them to the bedside while limiting their exposure to potentially non-actionable alarms. So let's look in our last couple minutes here in my section. Let's take a look at what are the results associated with continuous monitoring. So early on in the presentation, there was one study I put up from Perman which I put up as initial evidence that in-hospital cardiac arrest is happening on the ward. And in that particular case, 41% of arrests were happening in that environment. There's an additional layer of detail that's in that paper. And it's this differentiation between unmonitored ward environment and the monitored ward environment. So this was published in the Journal of the American Heart Association, so a cardiology-oriented journal. In this particular case, a monitored ward was defined as telemetry. And although it's not completely defined in the paper, in all likelihood, it's cardiac telemetry, so continuous ECG, and there's a good chance these patients had pulse oximetry as well. That third row within this table, and where that circle is, demonstrates that the monitored ward had the highest survivability of these events. So the survivors and who suffered cardiac arrest in the monitored ward significantly exceeded the ICU, which is not surprising. In more comorbid population, higher risk of adverse event, lower reserve to survive that event. But what's interesting too is the significant survival advantage versus the unmonitored ward. You can see those patients there on the right, and it's likely comes back to that illustration from Dr. Khanna. Earlier recognition supports earlier intervention and then prevention of more life-threatening deterioration. There's some additional evidence out there that supports the benefits of continuous ward monitoring. This comes from Dr. Michard, 2021, in anesthesiology, which is a great review of continuous monitoring in the ward environment. Here he highlights and his co-author highlight what they view as the most contributory studies to date. There have been some additional ones, which I'll get to here in a moment. But I think what we want you to become familiar with here, what type of benefits are being observed. So it's rescue events, ICU transfers, cardiac arrests, length of stay, rapid response team. These events are the metrics that are going to be used to measure the effectiveness of these technologies and care processes. And they're also going to come up in Marco's section, which is related to the economics. So first, here's a study that's from Dr. Tanzer, and this is from over 10 years ago. And this is from the United States. And in this study on post-operative units, they installed continuous pulse oximetry and created process of care around it, including a paging system, which would alert the bedside provider of a change in patient condition. And what they found in this study, if you look at that top panel, the top right, there's the intervention unit, the PSS unit, and then they have two control units. So that PSS unit is where continuous oximetry was installed. The control units, no change in care with a before and after period. What they found was that in that interventional unit, rescue events, this is an RRT, a code blue, for example, decreased from 3.4 to 1.2 events per 1,000 discharges. They also identified a significant change in the number of ICU transfers per patient days. If you look at those comparison units, there's no significant change in either one of those units, which works to control for the fact that care practice is changing in one unit. Does that impact the care in others? And it appears in those two units that outcomes did not change significantly during this study period. Over 10 years later, many of the same researchers have come back with a look at that institution's outcomes with this technology. What they found was that in the table in that box, in the units where surveillance is available, over 111,000 discharges. In the units where surveillance was not available, 15,000 discharges. So in the surveillance units, they had one death. That's 0.9 for 100,000 discharges versus 3 deaths in the unit without surveillance. The authors point out also that one death in a surveillance unit happened when that patient was actually not wearing the surveillance technology. So I think this is pretty strong evidence that continuous monitoring is improving care in that institution. This is another study. It's a different type of monitor. This is an under the mattress type monitor that measures heart rate and respiratory rate. And this technology was studied in a unit, a 33-bed med-surg unit, where they had a total of 2,300 patients with continuous monitoring versus 5,300 that were not cared for with continuous monitoring. Each one of these red boxes looks at a specific outcome metric. So the top red box in that left column is length of stay in the med-surg unit. The next one down is days per 1,000 patients in the ICU and associated ICU length of stay. In code blue events, we can see that in each one of these outcome measures, caring for patients with continuous monitoring improved those outcomes. This is just a look at the ICU data. We can see that in the control unit, which is the blue unit, in a green unit, which is the intervention unit, but pre-continuous monitoring, that red line, which is the post-intervention, the continuous monitoring group of patients, had a significant reduction in their length of stay, both in terms of their averages and in their maximum. A recent publication here in 2024 comes from Wake Forest and Dr. Khanna and colleagues. This is a retrospective look of propensity matched cohorts of patients. They had 11,000 in a continuous monitoring group. This is wireless wearable vital signs monitoring, 23,000 in matched controls. What these authors found was that outcomes they looked at which favor continuous monitoring achieves statistical significance across the board, with the exception of rapid response team activation. That's everything from ICU admission, in-hospital mortality, and then some specific organ system dysfunction, including myocardial injury and acute kidney injury. This is one of the secondary outcomes, which is looking at hospital length of stay and ICU length of stay. And finally, here's a paper that's under review currently. This is a paper that researchers at Cleveland Clinic are authoring. I'm one of the co-authors, and this study is also supported by my colleague Marco. This is a publication of a pilot study we did with continuous wireless wearable monitor made by GE Healthcare. It's called Portrait Mobile. In our first 250 patients, although we did not expect to find statistical significance here, we can see that to the left of that center line, Portrait Mobile, the unblinded group, favors it. To the right would be favoring intermittent monitoring. What we found in the Portrait Mobile group of these 250 patients, that all trends support the favorable impact of continuous monitoring in this population. And in this particular case, we measured this as both the duration and severity of abnormal vital signs. In this case, continuous monitoring was associated with an estimated 25% reduction in severely abnormal vital signs. There's a larger randomized trial ongoing, and we'll have those results, we're optimistic, the end of 2025. So as my final topic here, what are the barriers? So what I've presented thus far sounds great. Like, why doesn't everyone have continuous monitoring today? The reality is there are pretty significant barriers to it. In addition to changing how patients are cared for, changing nursing workflows, and the need to continue to accumulate clinical evidence demonstrating safety and efficacy across applicable patient populations, one of the biggest challenges here is economics. It's new technology being introduced into capital-constrained environments, oftentimes when separate reimbursement is not available. This is a study that surveyed almost 1,200 anesthesiologists in Western Europe and the United States. Economics from this group was the #1 barrier to implementing this type of technology. And with that, I'm going to transition over to Marco. So quick review, we did this patient safety reality check. We looked at abnormal vital signs do predict adverse events. We're not very good at finding those right now. We looked at what does continuous monitoring look like and some initial outcomes. And now with Marco, we'll take a look at what those economics look like. So I thank you all for your time and attention.
Thanks, Dr. Beers. So Dr. Marco Luchetti is going to talk next. I didn't mention at the beginning, but I can see from the participant list, we have lots of regular attenders to the ASGBI webinar with us this evening. You all know the ground rules. There is a chat function box and a Q&A. So if you have got questions, please feel free to put them in the Q&A and we'll get them to Dr. Beard and Dr. Luchetti at the end of the session. Thank you, Dr. Luchetti.
Yeah. Thank you very much, Sonia. Thank you, JW, for the introduction on the benefits of continuous monitoring in the world. Okay, so if you move to the second slide, so what drives cost avoidance with continuous monitoring? This was addressed already by JW in his talk, and basically we see five pillars basically. So it's fundamentally the length of stay in the medical surgical unit, it's the ICU transfer rate, the length of stay in the ICU, and then rapid response team activation and in-hospital cardiac arrest. So if you move to the next slide, we will see some of the evidence about the economics of continuous monitoring in the world. And next slide, you should see the experience from the Dartmouth hospital. So what they did in Dartmouth was to start a patient surveillance experience with continuous monitoring of oxygen saturation. And as you can see from this this slide here is basically that they were able to demonstrate a substantial reduction in the number of rescue events. So basically the number of rapid response team activations, the number of cardiac arrests, and the number of respiratory codes. So decreasing from before at 4.4 and to the after the experience, the patient surveillance start to 1.9. So and this was extremely significant. So this translates in terms of cost saving into annual cost saving of $1.5 million, basically. So this was for the initial study unit where this was initially deployed. So, and these savings, this annual cost saving are basically due mostly to the decreased ICU transfer rate. So this is what, in their experience, saved lots of money. And as you can easily see from the cost of the implementation, which amounts to around $170,000, you can easily understand that the return on investment of this implementation is easily achieved. It's interesting also to remark in their experience that they found that cost effectiveness depends primarily on the incidence of adverse events and the reduction of event rate. This was clearly seen when they expanded their experience to other institutions. And so basically what they noticed is that when the baseline event rate is high, cost effectiveness is more likely to be positive. On the other end, when we're in the units with low event rates, continuous monitoring is less likely to generate a remarkable change, And so cost effectiveness can be neutral or even negative. So the importance of the baseline incidence of events in that institution. If you move to the next slide, this is another study in medical surgical units. This has been already mentioned by JW in his talk, with a device, an under mattress sensor measuring respiratory rate and heart rate. This was done in 2014, and it's basically demonstrating again that the adoption of this continuous monitoring system is able to generate benefit in terms of reduction in length of stay, reduction in overall hospital length of stay, in ICU length of stay, and reduction in pressure ulcers. This translates into a cost saving that generates a highly positive return on investment. This is, let's say, an analysis of 5 years, but averaged in terms of annual cost saving. You see that with the two different models that they adopted, one is a base model, the other one is more conservative, but basically the savings range from $800,000 to more than $2 million. Another interesting point that they notice here is that the hospital break-even point is less than, of course, less before 1 year, and sometimes even in only 6 months, basically. And there was a net benefit per patient in the range from $200 to $700. In the next slide, this is a sub-study of the Prodigy trial. So the Prodigy trial was a large multi-center international trial investigating the use of continuous pulse oximetry and capnography monitoring. This was a very, very famous, very popular study in monitoring. And basically, this is a sub-study of that Prodigy trial. So they measured, again, respiratory rate and total CO2 and SpO2. This was done in 2021. And basically, they were able to demonstrate a reduction in high-risk patients of annual hospital costs by more than $500,000 and reduction of patient length of stay by more than 100 days. The break-even investment point is when the incidence of respiratory depression decreases by 1.5%. If you look at the graph on the right-hand side, you see very clearly that at 1.5%, that's the break-even point. But you see that increasing the percent reduction in respiratory depression, there is a corresponding increase in cost saving in a linear manner. So basically, the more you reduce the respiratory depression events, the more you save on costs. If you go to next slide, this is on post-surgical patients, again, monitoring continuous heart rate and respiratory rate. This was done in 2020 in the NHS in United Kingdom. This study was again able to demonstrate that the adoption of a technology, a device allowing for continuous monitoring in the ward. In this case, the comparison was between only news as a monitor strategy versus news plus the device. In this case, they were able to demonstrate a reduction in in costs that's attributable to ICU stays, reduction in cost of hospital stays, reduction in the cost of readmissions, and total cost at 30 days. So all the results of this study seems to say that the technology, in this case, has the potential to be cost-saving and cost-effective compared to the usual standard practice, again, which is intermittent monitoring of vital signs, spot check monitoring. Next slide. This is another study. This was done in the Netherlands, in Europe. Again, monitoring continuously monitoring heart rate and respiratory rate, another device. So consider that all these studies that I mentioned here have been performed with different technologies, different devices. So this is not just tied and attributable to just one single device. In this case, again, clear reduction in the length of stay, clear reduction in ICU admissions. So improvement in clinical outcomes, which generates in turn improvements in cost savings. You see here they were able to demonstrate reduction in ward costs, reduction in ICU costs, and reduction in total costs, of course. So patients were less likely to be admitted to the ICU. So at shorter length of stay, and these translated into lower hospital stay costs. Next slide, please. This is a study by JW, my colleague and my co-speaker today.
Sorry, Marco, one moment here. Vicky, I think we're one slide ahead right now. Maybe you could move back one, please. Perfect.
Yes, we have 2 slides about this this study. This one is again this is a cost-saving analysis. So this was a model designed to calculate potential cost savings for an average size US community hospital. So assuming a total of 153 beds over a 1-year time horizon. And you see in this model, they assume the number of annual discharges of 4,700 approximately. These was taken by US databases, and they assumed 2 different adoption rates. So they modeled the total adoption rate, 100% versus the 50% adoption rate. You see there are different clinical inputs, average length of stay in the medical surgical units, among patients without ICU stay or in patients prior to ICU transfer, length of stay in the ICU, transfer rate from the medical surgical unit to the ICU, RRT events, and intra-hospital cardiac arrest. So based on the Brown paper results, which has been mentioned also by JW earlier in this talk, basically they built this model, and also based on cost inputs, they were able to demonstrate, and if we move to the next slide, that there is a potential annual cost potential for annual cost savings that was estimated to be at depending on the adoption rate, so 50% or 100%. But even in the most conservative situation, 50% adoption annual saving were nearly at $3.5 million versus in the 100% adoption rates, nearly at $7 million. So very large, huge potential cost savings in these model studies. Interesting to remark here that the largest contribution, so accounting for half of the total, you see 3.5 million in the 100% adoption rate column. You see that this comes from patients that avoided serious adverse events requiring transfer to the ICU, meaning that if you are able to early detect deterioration, then you avoid more serious adverse events and you are able to avoid transfer to the ICU. And this is what generates the largest cost saving. The contribution by rapid response team activation and intra-hospital cardiac arrest seems to be minimal in this case. And if you move to the next slide, and this is coming to the end of this part, basically this is the more recent study that we performed. This is just an abstract so far, but we are working on the full manuscript, the full peer review manuscript. This is basically very similar to the previous study by JW and his group, and it's the application of that model used for coming from the United States data, basically applied to the NHS. So we were able to collaborate with Dr. Sadia Khan at Chelsea and Westminster Hospital NHS Foundation Trust, and we were able to get real-world evidence data extracted from the Chelsea and Westminster, and this data was used as a model inputs in this case. So you see the structure of the analysis of the model is the same as the previous study. You see, we modeled the number of annual discharge, 24,000, adoption rate, again, 50% versus 100%. In this case, same clinical data inputs. So again, average length of stay in the wards, length of stay in the ICU, transfer rate, rapid response team events, intra-hospital cardiac arrest. So you see here, we compare the standard of care versus continuous monitoring. And you see that this comparison is based on the reduction rate due to the implementation of continuous monitoring technology. You see in the bottom part of the table here, the reduction ratio that we have taken from the US model. So these reduction ratios have been applied to the comparison between standard of care and continuous monitoring. We have the cost inputs here as well, based on 2022 sterling pound, British pound. And if we move to the next slide, you see the results are very, very similar, or even more impressive than the United States study. So again, huge savings in both in case of 50% adoption or 100%. You see here the annual hospital cost savings amount to 4,600,000 pounds versus for 100% adoption more than 9 million pounds. So you see, these are very, very impressive savings. And these, of course, these savings are able to offset the cost related to the implementation of the device, the technology. Also, in this case, the largest contribution to cost savings came from the reduced length of stay for patients that were not transferred to the ICU. So meaning that this is the crucial point. Apparently, if we are able to avoid that patients go to the ICU, this is what generates the larger cost saving. In this case as well, the rapid response team and intra-hospital cardiac arrest contribution to the savings was minimal. If you move to next slides, we should be at the end, and I was just to give you some takeaways for today's talk. So basically, the current evidence, economic evidence, seems to confirm that the adoption of some form of continuous monitoring, you have seen that these studies were using different form of continuous monitoring, different parameters.
One slide ahead, please, Vicky. Sorry, Marco. We're one slide behind right now.
Thank you.
Sorry, Vicky, ahead. There you go. Thank you.
Yeah, and so the adoption of continuous monitoring seems to confer significant economic benefit. The implementation of continuous monitoring is associated with a highly positive return on investment. Okay, and this is able to offset the cost of the implementation. Hospital break-even points seem to occur within a reasonable time frame, so 1 year or less. Cost effectiveness depends primarily on baseline incidence of adverse events and on the reduction of event rate, that you achieved thanks to early detection of deterioration. The largest contribution appears to come from patients that avoid serious adverse events requiring transfer to the ICU. So avoiding transfer to the ICU is a major determinant of cost savings. This translates into a shorter length of stay in the ward, in the ICU, and in the hospital. And so far, at least according to the evidence so far, rapid response team activation and intra-hospital cardiac arrest reduction rate seems to contribute less to cost savings. With that, I thank you very much for your attention, and
brilliant. Thank
open
you,
to
Marco.
questions.
Yeah, so we've got a couple of questions coming in. We've got a few minutes left, so I'm going to just ask the first one, which comes from Demetrius Damascus, who's one of our exec members, and he's asked, is there any data on false alarm impact on work burden? So have you got feedback from nursing? Presumably it's nursing staff that this will have the biggest feedback to.
Yeah, I think JW can answer this. This is part of the Cosmos trial.
Yeah, this is really a key question. And if think back about that slide, it was the survey of anesthesiologists. What are the biggest barriers? There was economics, nursing, economics, IT, nurse pushback, physician pushback. And I think that one of the primary areas of concern for nursing is the alarm volume and the percent of actionable versus non-actionable nuisance alarms. There's reasonable evidence now that I think those alarms can be managed effectively. So Marco mentioned within the clinical research that we're doing, that 250 patient trial that's the GE Healthcare technology called Portrait Mobile, the total number of alarms per patient on average a day is less than 3. And the nursing staff, when surveyed, responded that over 80% of those are useful to them. They felt like it was meaningful clinical information and oftentimes leading to a change in therapy. And there's additional data, for example, from Dartmouth, that it's a combination of delays and alarm thresholds that can serve to significantly reduce the number of alarms and still identify those patients who are deteriorating effectively. So I think the technologies are advancing to a point where there's fewer technical alarms. Workflows are able to, I think, more effectively filter alarms till they get to the bedside staff. So I think that part is significantly improved. But ultimately, there's going to be staff that are going to deal with alarms they previously did not deal with. And it's really important to drive adoption and drive compliance if the clinicians recognize that the technology is having an impact, it's moving the clinical metrics that are associated with improved quality of care, that's, I think, going to enable them to, embrace this additional data source in caring for patients. I mean, it's an excellent question.
Yeah, so that brings us to another question that's come up. So many of your studies have looked at cardiac arrest, respiratory arrest, which for most of us on this meeting as surgeons is thankfully relatively rare. Is there any data looking at surgical complications, as in hypertension and anastomotic leak rate, return to theatre, and how sort of avoidance of those? Have you got data where it impacts on sort of surgical complications as such?
Yeah. So most of the data here, you're exactly right, Sonia, is related to length of stay, admission to ICU, et cetera. I haven't seen a whole lot about return to the operating theater as an outcome, but the causes of complication, it could be bleeding, it could be sepsis, it could be a number of different relevant pathophysiologic changes associated with post-operative patients that are going to be picked up initially with vital signs changes. So I believe that if we got into these records further, we could identify in the post-surgical population specific changes in their course of care, including who went to the operating room, who had a new medical diagnosis, et cetera. So it's probably there. It's just not part of this publication that I've seen so far.
Good. So Ravi Vora is on the call. He's also one of our exec board members, and he's asked, which single parameter do you feel is the most important to detect a deteriorating patient?
So I would say respiratory rate. I guess JW is agreeing on this. Respiratory rate is probably the most neglected vital signs today. Is something that we tend to underestimate and to and usually it's I mean it's something that when it's taken manually, it's something that you can easily mistakenly take. So basically having a system that allows you to continuously monitor respiratory rate is something that really can convey a huge benefit. But yes, I would say respiratory rate, and of course, if you have more than one, it's always more powerful, because even respiratory rate taken alone probably would not have the same predictive, I wouldn't say predictive here, but just the ability to early detect as when respiratory rate is associated, it's coupled with SpO2 or heart rate. I would say it's a combination of the three, but if I had to choose one, I would say respiratory rate.
That's fantastic. Thank you. I mean, it's technology. It absolutely, looking at the data is something that will come forward.
And also because and that's important, I think, also because saturation, you would say saturation is something that we always think would be the best one, the best but saturation is very easily confounded by supplemental oxygen. If you give oxygen by face mask, you lose completely the power of oxygen saturation as an early indicator. Yeah. You will see a decrease in oxygen saturation, but when it's too late. Yep. And that's the reason why respiratory rate is probably the single best indicator of deterioration.
Well, I'm hoping everyone on the call has enjoyed the webinar as much as I have. I can't see that this won't be a technology that gets embraced and adopted worldwide. I guess there's still some challenges, including sustainability and practicalities and finances. I'm almost certain that the AI component will become part of it. and it's interesting to watch it evolve and how it will apply to our patients in the surgical cohort. So thank you again, both Dr. Bird, Dr. Luchetti. I hope to see everybody in Manchester in November. Thank you again for your time. Take care.
Thank you, Sonia.
Thank you, Sonia. Thank you, everyone.